All right. Hi, good evening, everyone, and thank you for joining us. Welcome to the AEP ASRA Pain Medicine joint webinar, Neuromodulation for the Next Gen Interventional Pain Physician. My name is Mustafa Dodurgali. I'm a PGY2 PMNR resident at the Yale School of Medicine and Vice Chair of the AEP Residents and Fellows Council. On behalf of AEP and ASRA Pain Medicine, we're excited to have you with us tonight. This webinar was created for trainees and early career physicians interested in pain medicine and neuromodulation. And our goal is to provide practical insights into the field, discuss emerging technologies and future directions, and guidance for those considering a career in interventional pain medicine. Before we begin, I would like to thank Dr. Lynn Cohen for her leadership and support in making this collaboration possible. And we are fortunate to be joined by an outstanding group of leaders representing both PM&R and anesthesiology backgrounds. And we are grateful to them for sharing their expertise and perspectives with us tonight. The session will primarily consist of a moderated panel discussion, followed by audience Q&A in the last 20 minutes. So please feel free to submit questions through the chat throughout the webinar, and we'll do our best to address as many as possible. At this point, I would like to turn things over to our co-moderators, Dr. Becky and Dr. Wee, who will introduce themselves and our distinguished panelists.
Hi, everyone. I'm Becky. I'm a PGY2 PM&R resident at the National Rehab Hospital, and I'm also Secretary of AAP Resident and Fellows Council, and I will let V introduce herself as well.
Hi everyone, my name is V. I'm a PGY3 at Larkin South Miami Hospital. I'm currently the ASRA's co-chair elect for the chronic pain division. Thank you all so much for coming here tonight and spending time with us.
All right, now to introduce our wonderful panelists. First, we have Dr. Carayannopoulos. He is the Chief of Physical Medicine and Rehabilitation at Brown University Health and a full professor of neurosurgery and neurology at the Warren Albert Medical School of Brown University. He is dual board certified in physical medicine and rehabilitation, as well as pain medicine, and he did his fellowship training at Dartmouth. He currently serves as president of the Rhode Island Society of Pain Physicians. And we also have Dr. Elmofty, who's an associate professor of anesthesia and critical care at the University of Chicago, where she also serves as the Pain Medicine Fellowship Program Director. Dr. Elmofty completed both her anesthesiology residency and pain medicine fellowship at Rush University Medical Center, and she serves on the Education Committee of the North American Neuromodulation Society and is the chair for the Women in Regional Anesthesia and Pain Medicine Special Interest Group for ASRA.
So we're also going to introduce Dr. Trent Emerick. He is a triple board certified anesthesiologist, pain medicine specialist, and addiction medicine physician, and serves as the associate professor at the University of Pittsburgh, as well as the program director for UPMC's Pain Medicine Fellowship. Clinically, Dr. Emerick acts as the associate chief medical director and director of quality improvement and innovation for UPMC Division of Chronic Pain Management. He specializes in cancer, craniofacial, and pelvic pain. Let's also welcome Dr. Christine Hunt. She is the Associate Professor of Anesthesiology and Vice Chair for Quality of the Department of Pain Medicine at Mayo Clinic, Florida in Jacksonville, where she also serves as the Florida's Associate Director for Mayo Clinic Medicine Division. She's double board certified in PM&R and pain medicine. She also specializes in advanced interventional procedures, neuromodulation, as well as complex conditions. Nationally, she's recognized as a leader in her field. She holds prominent leadership roles as director at large for governing boards of both ASRA as well as NANS. And finally, we have Dr. Charles Odonkor. He is double board certified physiatrist and interventional pain specialist who also serves as associate professor of orthopedics and rehab at Yale School of Medicine. He completed his PM&R residency at Johns Hopkins and Pain Medicine Fellowship at Mass Gen Medical School. He also specializes in advanced neuromodulation and minimally invasive spine procedures, as well as a research focused on digital biomarkers, wearable technologies, and precision pain medicine. Thank you all so much for coming tonight. We're going to get started with the questions now. Mustafa, back to you.
Oops. Thank you, Becky and and thank you again to all of our panelists for joining us tonight. We would like to begin by learning a little more about your journeys into pain medicine and neuromodulation. So the first question is, what first drew you to pain medicine and neuromodulation? Was it a mentor, patient, or experience that shaped your career path? And I'll open it up to the group. Whoever would like to begin, please feel free to share.
I'll start. I think from my perspective, the transition from PM&R and incorporating or adding in pain medicine was a natural progression in terms of the way we approach patients and healthcare in PM&R, really using an interdisciplinary approach. So that would seem like a natural transition into pain medicine, which was really founded by John Bonica in the late 60s, using the same sort of rubric. And it really was a combination of biomedical and biopsychosocial perspectives on advancing care and function. So
That's a phenomenal perspective. Thank you.
I guess I can go next. I'll be honest with you, I was initially in the clinical pathology residency. At that time, I just had my first son, and I got the opportunity to do research with a very well-known pain physician, Dr. Bhuvanendran, and Dr. Lubinow. And that actually attracted me into that field. I initially wasn't thinking of anesthesia. I thought I was just going to kind of continue my clinical pathology pathway, but that ventured me towards that. And then at the same time, where I trained, it was very heavily focused in neuromodulation. So I got exposed to that quite early, and I was able to see a lot of the success stories and the return of function, and patients kind of the whole change of their lifestyle because they were able to manage some of their discomfort and kind of fulfill some of the things that they wanted to fulfill. So that I was very fortunate to have that experience, and that kind of triggered me to go to anesthesia, then pain medicine, and I incorporated neuromodulation into my practice for that very purpose.
Thank you for sharing that.
All right, excellent. So I think just to echo what everybody has said, I did my PMR residency at Hopkins, and when I was there, Steve Cohen was there at the time, and he was doing a lot of research. So as a PGY2, I just happened to kind of bump into him at some point, and he was working on some fascinating outcomes research. I got involved in that. And so, I've always liked to do things with my hands, and, being in PM&R, we have a lot of patients who have like chronic pain, whether, stroke patients or SCI patients, they have pain, and, we're doing Botox injections for these patients. But I think pain medicine actually opened up a different avenue, to look at things like neuromodulation. And I remember spending time in the OR, observing Steve and some of the other attendants there. And I was very fascinated by the fact that, they were doing a trial. This was my first time seeing one. And just to see how in real time you can actually interact with the nervous system and get feedback from the patient, and then basically, fine-tune the intervention that you're providing. So I was kind of blown away by that. And then from a science perspective, I just found it interesting that neuromodulation is one of the few therapies that seems to sit at the intersection of many things. Like, so you have engineering, then you have neuroscience, and then you have all these other specialties, anesthesia, PM&R, neurology. And so it was very multidisciplinary. And as a physiatrist, we're kind of, multidisciplinary at heart. So that kind of really drew me to the neuromodulations as a field. And then the last thing was that, I felt like this was one thing that we could offer patients that was really transformative, that patients could actually get their life back. It wasn't just throwing like a generic medication at the problem, but putting patients back in the driver's seat. And so, I think I was kind of fascinated by that. And so eventually, towards my PGY3 year, I had to decide if I really wanted to do pain versus sports. But I was more drawn to just the interventional aspect of things. And so I ended up, applying to fellowship. And the rest, they say, is history.
Okay, let's move on to the next question. Thank you all so much for sharing. Rebecca, if you could take it away.
Yeah, that was great hearing how you all came to the field, now focusing on the future and advances that you all see. What has been the most transformative advances in neuromodulation during your career, and where do you see the field heading over the next decade?
Yeah, I can take that one at least to start with too. So I'm about 11 years out of fellowship training. I feel like a lot's changed. Obviously, it's kind of cool in many ways to see how much has changed. And I don't necessarily think it's all neuromodulation too. The number of procedures, ultrasound guided procedures that didn't exist, many of which we've kind of stolen or adapted from acute or regional anesthesia that have now been applied to chronic pain is pretty cool. Lots of fascial plane blocks, some of which are building a stronger body of evidence. It's really cool to see. So I think the technology is evolving for neuromodulation. Certainly, there's a lot of cool things like closed loop technology, better batteries, non-rechargeable batteries, smaller devices. I think peripheral nerve stimulation is incredibly interesting to me, at least. When I was a fellow, all the PNS systems were off-label spinal cord stimulators that were placed, and now to see all these cool peripheral nerve stimulator companies and minimally invasive technologies is really cool too. I personally think it's probably going to undergo a big transformation again in 5 or 10 years, to the point where it'll be so pretty hard to recognize, and it'll seem old what we're talking about today. It's just such a fast moving field. Reimbursement, I think, plays a big role into that, because everyone, including CMS and private commercial insurers, are trying to save money. So to innovate and to make things more minimally invasive is a big deal. A cool area, I think, is the transcutaneous stimulation, right? There's a lot of companies, there's universities looking at applying patches like EKG leads to the skin, and basically triangulating the waveform to converge on the spinal cord. And it may seem in 10 or 15 years like ancient history when we say we used to have to dissect down to the epidural space to implant a spinal cord stimulator, because we can do it all using AI and transcutaneous leads too. So I think there's so much cool innovation. It's really hard to say where it's going to go, but I think we all acknowledge that it's probably going to change pretty fast too.
I think I'm the only one who hasn't. Sorry, go ahead.
Dr. Hunt.
Yeah, I was gonna say I think I'm the only one who hasn't talked yet, so I should probably speak up. And thanks for having us. So I think that it's a great question. When we think about neuromodulation, the field itself, sounds exciting, feels exciting, and is interesting in a lot of ways. I think, and exciting in a lot of ways, and it's a therapy that we all use. Dr. Emerick already pointed out, I think, a lot of the kind of advancements and neuromodulation that people think about, right? Closed loop. The trend for spinal cord stimulation has really been, kind of how do you make the battery smaller? How do you make it last longer? How do you also, from waveform standpoint, how do you make waveforms more effective? The whole advent of non-paresthesia based waveforms, which emerged, gosh, I want to say when I was late residency, early fellowship. And so that kind of brought in a new paradigm, the non-tonic waveforms. And then now with closed loop technology, I think also some of the automation is really interesting from the standpoint of programming. I think what's going to be incredibly important is more individualized technologies and therapies, doing a better job of predicting who's going to do well and how to prevent some of the things that are challenging in the field, like habituation, for example, right? How can we predict who's going to do well and who's going to do well in the long term? And then I think what's really interesting from a physiatry standpoint, and Dr. Carayannopoulos has lectured about this, is what are the right types of rehab or activity protocols to pair with some of these therapies and treatments to allow patients to really take advantage of some of the neuroplasticity that can evolve in terms of pain management. So I think that the idea of taking a technology and a therapy and being a sort of like a technician, having some surgical skills, and implanting these is one way of thinking of it. But I think when we really want to look at where we're bringing that therapy into the next like how you really advance this, right? The companies will continue to try to look at smaller batteries, novel waveforms, but then our job as physicians is really thinking about who's the right patient for the therapy and how do we do a better job of looking for more predictive power of who's going to do well, how to prevent habituation, and have more durable long-term treatment for patients with chronic pain. It's a tough problem to solve.
Christy, if I could just pick up on what you said, I think it's great points. I think one of the things that I've realized I've been out 20 years since fellowship is just the evolution in focus on outcomes. Initially when I started, we were just happy that it worked and patient felt the paresthesias where they were supposed to. But, now we're really looking at, as you said, predicting who are the right candidates and when, and really incorporating the full spectrum of the team, the pain medicine interdisciplinary team, to make sure that we are doing the right procedure for the right patient at the right time.
Excellent. And I think just to piggyback on that, I was exactly going to talk about outcomes. One of the things that has plagued pain medicine generally is the fact that we've all been kind of married to NRS scales for a long time. And so globally, there's sort of this evolution towards moving beyond that, because suddenly, there are other outcomes that we can talk about, even when it comes to like healthcare utilization, resource utilization, right? Rehospitalizations, medication usage, but also functionally being able to have very objective ways of tracking things like sleep, mobility, activity, etc. And I think that brings a lot of excitement, because now we have wearable devices, for good or bad. Some people hate it, some people love it. But I think it's actually going to move us towards a more scientific approach and being able to collect objective data. Because, one of the big concerns we have right now is the concept of virtual explants. So, you put these devices in patients and you assume that, no news is good news. You don't hear from a patient in 5 years. You have no idea, are they still using the device or not? Most patients come back, they tell you, I turned this thing off 2 years ago. I haven't been using this, doc. So if there's a way, now we have the ability to do remote monitoring, at least some of the companies do. And so I think, with wearables, with AI, with all these like machine learning models, it's exciting because now we can collect other data, right? Beyond just pain scores, like how well is the patient sleeping? Because at the end of the day, yes, it's great to have less pain, but truly, what do patients care about? They want to be able to go live their life. They want to go play golf. They want to play. Grandma wants to play with their grandkids. They want to go grocery shopping. They just want to live their life. And so I think being able to measure other things beyond just the pain scores, it's quite promising. It's still in its infancy in terms of how to do this exactly. I know some companies have paired up with IBM and whatnot to look at how to incorporate wearable data. They still haven't figured it out yet. Some people are thinking about how do we actually use the IPG itself, because it has like activity monitoring, active insight embedded in the IPG. But I think this creates a lot of exciting opportunities for innovation, right? And also to be very more objective in terms of what we are measuring. So the future looks promising.
Yeah, I'm just going to throw a quick comment and then we can move on to the next question. But I think many people have kind of, compared this to going from cruise control, right, to a self-driving vehicle. And I really do think that that's where neuromodulation is going, with all the information that we can capture from that individual patient and phenotype them, hopefully with some of the AI generated information that we'll be able to incorporate. That's basically how I would sum it up.
I kind of to piggyback on that too. I also think that neuromodulation will expand as far as targets. Like technically, transcranial magnetic stimulation is a form of neuromodulation. Oftentimes, it's thought of more in the psychiatry side for refractory symptoms or depression. But that's an interesting, exciting area for future pain relief. And then there's all the neuromodulation for other symptoms other than pain that we as pain physicians may get involved with, whether it's vagal nerve stimulation for various symptoms, GI, immune system related things, stimulation of the stellate, cardiac indications. These are all things that we potentially may lead the way and even find that our value extends beyond just what a traditional pain physician may do, just because we have the expertise too.
Yeah, Trent, I think as you were saying that in the UK, isn't it, might be wrong, but for cardiac reasons and angina pain, I think they're already utilizing spinal cord stimulation for that.
Great point.
All of which are phenomenal points. Thank you guys for commenting on that. Seems like a lot of self-direction and more agency for patients with pain using this future technology. So that segues directly into our most exciting innovations. So among SES, DRG stimulation, PNS, restorative neurostimulation, and emerging technologies, what innovations are you guys most excited about today?
I think in a global perspective, I think one of the things I'm most excited about is the personalizability of some of these offerings. So it's no longer just an SCS that's trying to work for all patients. It's now trying to find the right device for the right patient. So whether that's a restorative device to functionally restore chronic low back pain, or whether it's a palliative stimulator to address chronic leg pain, or whether it's a non-invasive tool that could help with not only pain but other like mood disorders and movement disorders, et cetera, et cetera. I think that we now have options that we never had before to make sure that we're looking at the patient as an individual and not just applying a blanket, treatment option.
And kind of follow up on that and looking at not necessarily anatomical targets, but the neural networks that are involved, right? Not every patient has the same neural network, and us being able to understand that pathophysiology will hopefully help us determine which device is best for which patient as well.
Thank you for sharing your great insights. My next question is about patient selection, which is critical. So what characteristics make someone an ideal neuromodulation candidate, and what factors give you a pulse?
So I think I can take that. So for me, generally, when I am approaching neuromodulation and having conversations with patients, specific things that I really look out for. Number one is, is there identifiable sort of pain generator? Number one. Typically, I find that when patients are coming in and we haven't quite clearly defined why they're having the pain and what's causing the pain, then generally this might not be a very good intervention. Because if you do have something structural and then you end up putting a device in the patient, ultimately ends up failing. So having a really clear understanding of why the patient is coming in and what's causing the pain, it's like my first approach. And then as a segue from that, I also look for, factors like catastrophizing, patient mental health. Generally, and the research also shows that patients who have very high levels of catastrophizing, low self-efficacy, they tend not to do very well with these devices. And so I usually actually, at our institution, we screen for this when patients come in. And we try to have a conversation about a brain-first approach so that they know that this is not just something we are just putting in passively and then you call it a day, but I want to see how actively participatory the patient wants to be in their plan of care. So it's a sort of shared decision making. We make goals together. If I do find that the patient is having more kind of diffuse phenotype of pain, I usually will not offer neuromodulation as a sort of first line intervention. So, specifically looking for, high self-efficacy, clear identifiable pain generators, and then also how motivated the patient is. This is sort of my go-to approach in terms of patient selection.
I think that those are great answers. I think you ask 100 good doctors this question, you'll get 100 good answers, and all have different answers. I think we all have different, but this is the most important skill set to sort of develop when you're doing a lot of pain management, is really considering the patient. I start out every consult with a question of, I say a line or two about, so that they know that I know why they're there, right? Dr. Smith referred you for XYZ, maybe, you had this surgery or whatever. I always like to, and I say, tell me what you are, tell me basically what your expectations are, right? Ask them, set the agenda for me. What do you want to get accomplished during our time? And people never ask patients with pain that question because they're going to talk too long. you will get so much information, right? Plus the patient will feel like they were heard and understood, right? It will understand what their expectations are. Are they catastrophizing? Are they, are they seeking treatment or that you don't provide, right? Or you're the 15th doctor and they've heard just wonderful things about Dr. Odonkor and everybody else is terrible, but Dr. Odonkor is the best doctor ever, right? That's a red flag right there. But just whenever with like that splitting thing, right? So it gives you a lot of data and information. It kind of tells you where the patient is on their journey and everything else. So there's a lot of listening to and understanding who the patient is and their expectations. That's also very useful when it comes to any sort of interventional approach, right? So the more you have that chronic widespread pain, I feel the less likely the patient is to respond to any sort of interventional therapy, right? Whether it's an epidural or a trigger point or a spinal cord stimulator. So even though some pain may be a little bit ill-defined, but often in the context of prior surgery, features that are neuropathic, all these things can respond a little bit better to neuromodulation. But I think that expectation setting and the patient having reasonable expectations is super important, right? And then trying to avoid some of that chronic widespread pain, or patients who have chronic widespread pain. They might be dealing with central sensitization. And so when patients are really having that strong central sensitization piece, those are associated with poor outcomes. Also, high opioid utilization. There's different numbers here, and people have different thresholds for what low OME is, but generally trying to keep it below 50 is pretty reasonable. Patients with higher OME utilization are known to have poor outcomes with neuromodulation therapies.
Yeah, when patients come to me, I usually tell them you're a book and you have about 30 or 50 chapters that I need to learn before I can fully help you. So I'll be honest with you, I don't offer neuromodulation on my first, second, third, fourth, or fifth visit. I need to know them for at least a year. And that doesn't mean me doing procedures for at least a year. That means me getting to understand every aspect of their life, their lifestyle, their psychosocial, their eating habits, their sleeping habits, their activity habits, their compliance, what they want out of this. Because I think that is the best way that you're going to determine how you can help them and how they can help themselves as well.
Yeah. Another practical thing is when you're like, as far as who we pick for neuromodulation, in many cases, I'll feel comfortable offering a trial, whether it's PNS or SCS, if they meet some of the FDA on-label indications. Obviously some systems don't have trials, and I always think it's just a much higher threshold to cross to offer the permanent. And so that's kind of one of those soft skills I think that isn't necessarily in a book, but that discussion when you're taking out the trial, it means so much to me. I'm looking for the patient that by the time they come in for the trial has already messaged me 3 times asking where they're going to, when and how they're going to get the permanent implant. Ask me, all these questions that show that they love the device and they're already, looking at the next step because it's changed their life so much. The patients that I see in clinic that are 50-50, or you almost feel like as a doctor, like we shouldn't be in a position where we feel like we have to convince them that they need it or persuade them that they need it. Like those are patients that may like it for a few months until the placebo wears off or changes. And then on top of that, you may have an amazing rep, but the reps kind of also add their flavor and momentum can build. And they say, as you take the device out, they've already kind of planted in the patient's mind that they're going to, be ready for the permanent. And then you kind of dig in and find out, the patient's debating, is it 40% pain or 50 or 60? And to me, all of those are no go. Like I'm looking for the home runs of, this has changed my life the last week or two. I'm ready for the permanent. I've already, looked up when I want the surgery, and I've already looked at my job and when I can request off. Those are the ones I think that I like to cherry pick that do best with neuromodulation, at least personally for me, just to minimize explant rates too.
Thank you. That was really helpful to hear your perspective on patient selection. Going off of that, once you have the patient selected, do you think neuromodulation is still being offered too late in the treatment algorithm? And how should that decision evolve over the next decade?
Yeah, I think it's a tricky balance between how, between, how long do you take to get to know the patient versus we know that the longer and the more chronic a person's pain is when it's not been successfully treated, we know the harder it's going to be to manage that effectively. Now, there's probably a lot of nuance to those layers, right? And a lot of other factors. But we do think that the longer chronicity takes place, the harder, more challenging it may be to treat. So if I feel really confident of indication and pathophysiology and I feel that, expectations are reasonable and so forth, I don't feel like I need to make them jump through a whole bunch of hoops to go to neuromodulation. I also treat a lot of like brachial plexus injury and part of the brachial plexus clinic and treat a lot of patients with neurological problems. And so I reach for PNS specifically, like very liberally, I would say, like, especially the temporary devices, right? I would much rather, like, I'll have a patient who might be a young patient who's had a traumatic brachial plexus injury and they've had surgery to kind of for neuro recovery. And if they're, 6 to 12 weeks out from surgery and they're having horrible neuropathic pain, like, why wouldn't I offer peripheral nerve stimulation to peripheral nerve where I feel like that can be useful, right? So I think it's about like, when do you pick that correct tool? And the balance is definitely somewhere between being aggressive, right? Which I feel like is just like not a great thing, probably. I like everybody listening, please, if you hear nothing else, don't be the person to a year out of fellowship, like post on social media, here's how many implants I'm doing or something like that, right? This is not the goal, okay? This isn't about trying to I don't know, trying to sort of have the most or be the most or anything like that. This is about people and patients and lives you're taking care of. There's like nothing more important than that. So when it comes to, is it too early or too late in the treatment algorithm? Understand that when it comes to treating pain, the longer a patient is experiencing chronic pain, the more challenging that can be to manage, right? So whatever your tool is, whether it's neuromodulation or something else, trying to really be appropriately aggressive in managing that. And then recognizing when the tool is the right thing to employ. You want to at least maybe make sure you're trialing 3 to 6 months of maybe, depending on what your threshold is, right? 3 to 6 months of conservative therapies, and also depends on the situation, right? Like a traumatic brachial plexus injury, you're not going to that pain may change over time, but rehabilitation is not going to restore that function, nor to like maybe a complete cord transection, something like that. So there's a lot of layers to that question, I think, but just bear in mind that the longer a patient is dealing with sustained, significant chronic pain, the harder it's going to be to manage. Plus, they're suffering for longer.
I just want to add something. I think we've spoken, several have spoken about understanding expectations of the patient, but I really think it's also important to set expectations for the patient and make sure they understand the treatment paradigm. It doesn't stop at the implant, depending on the device or the technology. It really needs to be looked at longitudinally, and that really gives you the ability to assess the patient's understanding and also buy-in and their ability to see this through. Because if they think that everything is going to get better magically after the implant, then it's not going to be a good outcome.
Yes, I think that just to add to that, it's very important. In my practice, I always emphasize to patients that pain has many sources, and importantly, most of the pain comes from the brain. And there's not one magic bullet that I have that is going to automatically fix or cure this problem. So this is like a very key aspect in terms of patient education when I'm talking to them about anything. Like, there's nothing that I'm going to offer you that is going to cure all of your problems. Pain is not just physical. There's also an emotional aspect to pain, right? And sometimes we forget this when we talk to patients. And so I really want to emphasize when I talk to them that, clearly you're coming to see me because you're in pain, but there may be other aspects such as the emotional components that, has to be kind of incorporated in the treatment plan. And typically would, incorporate something like either pain reprocessing therapy or some kind of brain approach so that they understand that it's not just about having this tool, but there are other faceted strategies to come at addressing the problem with the pain.
All of them are really good points. Dr. Hunt, you said longer the patient is experiencing chronic pain, the more challenging it can be to manage the pain. So, what would you say the outcomes that should matter the most when defining the success? Is it pain relief, quality of life, return to work, or something else entirely?
Yes. Yeah, so obviously it's a little bit of a joke, but it should be multifactorial, right? It's multifaceted. I could not agree more with Dr. Odonkor about the VRS like 0 to 10. It's one way of asking the question, but you really want to look at multiple domains. So you want to look at pain, function, quality of life. Sleep to me is super underappreciated. If you dive into the data, what's really interesting, and we actually saw this in some of our own internal data, patients who had pain and trouble sleeping, I have to say this the right way to make this clear. Patients who had pain and difficulty sleeping or poor sleep, right? So, kind of, and that's self-related. Those patients actually had some of the best long-term outcomes with the therapy. And I asked myself, why might that be the case, right? There's probably a lot of different answers to that. But patients where sleep is also like a big part of what's disrupting that quality of life, they get a twofer. If you not only help with their pain, but then also help with their pain enough for them to get more restorative sleep, independent of the analgesia, by increasing that sleep quality, maybe because their pain is better, that's also going to have an extra effect on pain relief, quality of life, all these other things. So it's very multifaceted. And so when it comes to, you might have a patient where I've had patients who've had life-changing, what they describe as life-changing responses to spinal cord stem. They'll say they had 30% pain relief, but their life is completely changed in positive ways. And that's the hard part about subjective pain scales, right? You might have patients who say their pain relief is almost 100%, but they're still having troubles over here. Or so it's really multifaceted. You need to get a sense of how is this really improving their quality of life. And again, some of my patients have severe neurologic injury and problems. This is a big game changer for them. So you want to find different ways to capture that and their function. And are they participating more in life activities? Are they making it to their grandkids, baseball game? Are they going to church? Are they, able to return to work? So as much as you can, thinking in your practice how you can efficiently gather that information, I think is super important for understanding how they're doing.
Thank you, Dr. Ram. That was very helpful. My next question is about the access barriers. So what are the biggest barriers preventing patients from accessing neuromodulation, and how can our field address them?
Insurance. That's ding ding in all of medicine. That definitely is a big priority, and we all know that. Also, not all patients get referred to the pain clinic, right? Not all patients are aware of all the different types of modalities that we can provide. So, we're definitely getting better at it, but I think it is still important on our part as pain physicians to advocate what we do, what we have to offer to all the different types of patients that are out there. Part of that is on us, the education part.
Dalia, that's a great point. I think also, if you just look at the social determinants of health and the broader healthcare schema, the same patients who have limited access for, child maternal health or for glycemic control or whatever also have limited access for pain. So I think those are things that societally we have to address or evolve if we want a healthier society.
I think it's also connected to the previous question in terms of the outcomes. A lot of the times we often don't think about the public health sort of implications of some of the therapies that we have. But currently, the reason why insurance is a pain in everybody's butt is probably because the data that we have in terms of looking at healthcare resource utilization for some of these therapies is not that great. And so if we can actually accumulate more outcomes when it comes to things like ER hospitalizations, number of headache days, for example, for patients who have PNS, hospital neuralgia. So having these sort of hard metrics, right, to show that it's not just for the individual patient, but also on a global sort of scale that we are actually helping the health system. Maybe upfront, yes, initial cost might be higher, but like longitudinally that you might actually be cutting cost indirectly, that might help push the needle in terms of policy when it comes to dealing with the bane that is everybody's existence these days with insurance. But I think those two go hand in hand. And also advocacy, actually, and pushing more. Now, I know all of us, myself, we're all very hard pressed for time. But clearly insurance is going to keep getting away with murder if we don't push back. And one way we can push back is really by having data, right? And so I think the two of those things go hand in hand.
But I do think the reason we've had such limited data is because we didn't have a way to collect the data accurately, right? Everything was subjective, even
Right.
like a number of headache-free days, that's just by word of mouth. So
Right.
I think as we transition into the future, with, again, the wearables, AI, I think we're going to be in a better position to be able to provide that.
I'm going to be a little bit of a contrarian here and say I think that we do actually have really good data from high quality RCTs. Problem is that there's a lot of industry involvement there, and payers do see that, but the data is still good, right? But they don't match up to real world outcomes. And that healthcare utilization remains high. And even though that data is not publicly published, payers are looking at that, right?
Right.
And so that's where it remains our responsibility to do a really good job of patient selection and think about optimizing outcomes. That's why I'm really passionate about how do we get patients to be functional. A good friend and mentor of mine wants patients by 6 weeks to be really feeling good with that therapy, right? And if we're not, what else do we need to do? How can we harness those neuroplasticity changes in a positive way in that first initial period after implant? I think there's so much more that we need to be on top of when it comes to outcome measures beyond just doing the procedure and making sure patients are following post-activity instructions. It's a whole area that remains relatively unexplored. And I think there's multiple reasons for that, right? What is the optimal, activity cadence? What are the things not to do, right? But how do we try to really take advantage during those first 6 weeks when their activity is limited to engage in neuroplasticity in a conscious manner? So I would say that I think that even while I'm always for more data and better data, those are always good things. I think that a big part of this is healthcare resource utilization. And does that change? There are some studies showing that, but again, there's a lot of industry influence there, and these patients get a lot of time and attention. So I think we really need to think a lot about how do we improve those outcomes. The last thing I'll say is outcomes after lumbar fusion surgery are not great. They're not great. They're not great. Everybody knows they're not great, right? They're still paying for all the lumbar fusions. So it's a lot more complex than just demonstrating good outcomes and good data. And there's multiple things to it. But shameless plug for getting involved in advocacy in your healthcare organizations and healthcare societies, because this is the way to really help move the needle. There are ways to do that. And that includes getting involved with the AMA, as well as your medical societies, because that is going to continuously be an issue for all fields, including pain medicine.
Thank you. I love that plug for advocacy. Back on the topic of outcomes, I was wondering how you all think that AI, wearables, remote monitoring, and digital health will influence patient selection, programming, and outcome assessments.
So I think there's definitely a big role for wearables, in terms of many different facets. One of it, as we already have spoken about, is sleep. These days, you take your pick. There are many different kind of wearables out there. The challenge is that currently, in terms of research, there's no really standardized measure or standardized way of evaluating, what all of these different wearables are kind of measuring and collecting. And there's very high variability in terms of sensitivity and accuracy, et cetera, et cetera. And so, a lot of the research in this area is sort of in its infancy. Our group, we've been looking at with physical activity and just monitoring daily activity as sort of one proxy, in terms of outcomes with wearable devices. But I think that there are many, many, many data points that one can collect. But I feel like, comparatively to a field like cardiology, we are kind of way, way behind. We are kind of in the dark ages, but, that's also exciting because that means that there's a lot of opportunity for innovation. But, without a doubt, I think that is the way of the future, truly, and being able to collect, the challenge also is that these wearables, there's very large data sets that you're going to be collecting, and how to make sense of it. like trying to figure out signal from noise. But I think we have a long way to go. But from my perspective, without a doubt, there's a big role for how we're going to utilize these objective biomarkers or objective measures of function, and to translate into better ways of tracking what we are doing in terms of our interventions and how effective they are.
This kind of reminded me of not a story, several stories during my fellowship. We did see a lot of workman's comp patients and patients that came with, the diagnosis of CRPS. So we would see these patients, they had Budapest criteria that fit everything. And then 2 weeks later, we would get a videotape from the nursing workman's comp nurse, right? We felt like the biggest idiots, but it was observable data in an protocol environment, right? So I kind of feel like, again, I'm not saying that we're being detectives or spies, but yeah, when you're being observed, your reaction is going to be a little bit different, right? Your physical exam might be different. So it would be great to be able to capture this information as the patient goes about day by day. And I think that's what we're headed towards with wearables. But when you were talking about that, I'm like, oh my God, I remember all those days they brought us these videotapes and we were watching, we're like, oh my God,
Yeah.
he tricked us or she tricked us.
I mean, I think the other aspect of it is also for patients, because sometimes, patients come, you ask them, how's everything going? Oh, everything sucks. But turns out just this week, something bad happened. And so the filter through which they're looking at how the actual therapy is doing is really based on recency effects, something that just happened, right? An example, we did a study where we actually looked at activity data for patients post TKA, and to see how well they've done after the knee replacement. And some patients come, they tell you, oh, I'm doing great. Others like, everything sucks. But then you're like, hold on, here's your activity data from the last 6 months. You've actually been 60% more active than you were before the surgery. And this is actually what the data is showing. So sometimes it's like, oh, you know what? Now that you say that, you're actually right. And so sometimes the kind of feedback you might be getting from patients might not be quite reflective of what their perception is. And sometimes being able to have that data to show the patients themselves that perhaps you're actually doing better than you think you are will be another component actually to consider.
I wanted to mention a couple words on predictive analytics. I think that's going to be a bigger part of the AI future. We have, like Dr. Hunt was mentioning, the real world data is crucial, and now at many institutions and universities and publicly available data sets, there's just so much big data available that you can look at who's getting what device or what surgery or what neuromodulation device, and look at outcomes. And so in the future, when you meet a new patient who comes in for an SCS, you may be able to match before even meeting them 30 or 40 or 50 covariates that explain, their pain history, their demographics, their age, their type of, diagnosis, and it'll spit out a percent success rate or a chance with each type of neuromodulation device or therapy or medicine. And so I think we're going to go in with a lot more information. Obviously, the payers will also maybe use that for denials or approvals as well too. But we may have another tool, that actually, matches patients with real world data of how likely they are to succeed with a certain type of technology that can supplement or complement what an RCT shows us, but just on a more personal level too.
All of which are phenomenal points. Thank you. Let's shift gears for a bit. We have two questions right now from the chat. So the first question is, thank you everyone for taking your time to panel this discussion. Several of you have mentioned the biopsychosocial aspect of pain and its importance for screening and setting expectations with patients. What non-interventional therapies targeting the psychosocial dimensions of pain do you find most effective as adjuncts to neuromodulation, and how do you integrate them into your practice? How do you get patients to buy into it? And we're going to have Dr. Emerick answer this question, if that's okay. Dr. Emerick, you're muted.
Thank you. Yeah, of course. And I think my answer, I think it goes back to something that Dr. Elmofty was mentioning too. There, you definitely have to consider the biopsychosocial aspects of where the patient's coming from. It doesn't just mean having a therapist or a psychologist involved with it too. I think it's making sure that they're stable and they're optimized. We have a battery of questions that we ask the patients before they present for their first visit as a new patient. And we ask them, what percent relief are you expecting from visiting the pain clinic? And that's super telling to me. If they say 0%, that's a certain discussion I have with a patient that maybe they need to leave a little bit of room for optimism, and there's things that maybe they haven't tried. If they say 100%, then I have a totally different discussion, but equally important about how that might be unrealistic as well too. So I know that isn't necessarily a non-interventional therapy. It's more of a question or a battery of questions to ask. But I think even simple psychiatric questions or behavioral questions, and this also ties into what Dr. Carayannopoulos said about, catastrophizing, can really help you screen and put some guardrails around when you offer certain neuromodulation devices.
Thank you so much, Dr. Emerick, for taking the time to answer that. The next question we have for the panelists is, what is the panel's experience with multidisciplinary stimulation devices? And anyone can comment on this.
So I was one of the PIs for the Reactivate-B study, which led to FDA approval. So I have extensive experience with it. I think it's a terrific option that we did not have prior to sort of this treatment paradigm shift. For years and years, we were looking at pain medicine is really palliative, and restorative neurostimulation is exactly that. It's restorative. It's looking at function, which really aligns well with some of the physiatric goals that we have. But again, it boils down to patient selection. So it's all about finding the right patient for that therapy. From my personal experience, I think those that do well with multiplicity stimulation tend to be a little bit younger, have less sort of chronicity of pain, and really axial pain that's more axial non-radicular, that have really realistic goals to improve. Because this is a longitudinal treatment paradigm. It's not like you turning on and off the switch. It really should be coupled with a rehabilitative treatment with sort of set goals and expectations. Finding the right candidate who would do well is really key.
Thank you. The next question that we have in the chat is, thank you all for doing this. Have any of you had anecdotal experience in utilizing neuromodulation for treating chronic abdominal pain?
I think
that
go ahead, Christy.
Go ahead.
I was just going to say chronic abdominal pain is also one of those challenging pain syndromes that you really need to understand the etiology. If you have an etiology that you can target, then these patients can definitely benefit. I would say I do have some patients who are doing pretty well, but it wasn't the patient that had like the diffuse abdominal pain without an etiology. Somebody who had a pinpoint etiology that neuromodulation could target.
I've had some good success with DRG for patients who have like post-herniorrhaphy pain, but there's a component of abdominal pain involved. Those patients have done really well. I've also done some temporary PNS devices as well for abdominal pain, and with pretty good outcomes.
We have one more question in the chat, and it's, what age range is the younger age range?
You mean like who's the youngest patients we've implanted a neuromodulation device in?
I think there's saying that because multiple people have said the terms like, well, that's more for a younger patient or an older patient. I think that's kind of what they mean by that. I don't know that there's really probably when you say younger and older, there's not really studies that kind of give clear cutoffs of this is the right candidate for restorative neuromodulation because they're below 60. I think that a lot of us are kind of probably using that as a substitute for things like, is the patient more active, or are we thinking more of a palliative kind of approach versus not? I live in Florida, so I have a lot of very active older people. So I don't know. I think that probably a lot of us don't necessarily look at patients just at, are they older or younger to, that's probably more of a fear I have with opioids kind of, right? Like I have a really young patient, like that's going to be, I'm going to treat that person totally different than I'm going to treat somebody with like, I don't know, cancer or something like that. So, but when it comes to therapies and treatments, sometimes it's really meeting the patient where they're at, and age is a component of that, but so is activity and lifestyle and other things.
Thank you. The next question we have in the chat is, in developing neuromodulation therapies, especially the wearable devices, and using them to predict success rates for various therapies, how do we continue to develop this technology but prevent insurance companies from using these findings to deny patient treatment and rather keep it as a physician provider assessment tool?
That's a very good question.
Well, I think just like anything else, it's the interpretation of the physician of this data that's hopefully going to reflect the outcome. So yeah, we'll capture all this data, but it's up to us how to interpret it and how we reflect it and how we document it in our EMRs. So that's going to be a big key. We're not going to just want to plug information in. We're going to analyze and give a summary of what this means for this particular patient.
And remember, ultimately,
sorry, Christy, go ahead.
I know, I was just say payers have the ultimate data on their end in terms of healthcare utilization, right? So that's the other thing that they're looking at is like, is this actually resulting in a change in healthcare utilization patterns? And that's the data that a lot of us don't have access to. So I think that's the big piece of that is more something that should be more at top of mind than just the, I think data is democratic, right? Like there's nothing to be afraid of with data, right? Let everybody look at the data, data is data. That's just the other piece to be thinking about. Is this actually changing healthcare utilization patterns or not?
Well, I also wanted to add, I think it's really important to enlist the patient in advocating for themselves. And that may include advocating for themselves with the insurance company, with their provider, with their community. But this has to be a partnership between the patient and the provider or the team in order for this to succeed.
Yeah, I totally agree with that. I did see a meme on social media where you have the patient and the doctor were wearing gloves and boxing each other, and the insurance company was carrying a huge briefcase laughing on their way to the bank. And I think it's pretty reflective of what we are dealing with now because, current healthcare climate, it's almost like physicians and doctors have been pitched against each other, right? But we are literally the ones in the trenches, and then the insurance companies are sort of the overlords. And so I think to your point about patients really being involved in this, it's a partnership. I think a lot of the times patient stories go a long way, right? If some patient goes online and says, you know what, I have this condition, etc. And so whenever I meet with my patients, I always tell them, listen, if this thing is denied, you and I think I'm going to come more on you because as the doctor, if I do a peer-to-peer, they're just going to tell me this is not a covered benefit. End of story. You don't even get to talk about the patient. Okay, sometimes it's literally a waste of time. And so I tell the patients, if you pick up and say, listen, I've paid my premiums, I don't understand why this care is being denied. Explain to me why that is the case. Then sometimes you get a different decision. So definitely partnering with patients will go a long way. And again, I know we beat the dead horse about advocacy, but I think policy goes a long way. And until the vested interest in changing our current scheme for insurance, we have a long way to go. But yeah.
Thank you for all the questions in the chat, and it's almost 9 p.m. here in the ET time period. And thank you so much for our amazing panelists for sharing their perspectives tonight. Thank you, AAP and ASRA Pain Medicine, for supporting this collaboration. And we hope tonight's discussion provided valuable insights into neuromodulation and career in pain medicine. We also encourage everyone to become involved with both AAP and ASRA Pain Medicine and to take advantage of future educational opportunities. And thank you all for joining us. Have a wonderful night.
Thank you.
Thank you, everyone.
See you guys.
Yeah, everyone, take care.
Thank you, guys. I think it was